Okay, well, this of course is my this was going to be the subject of my main talk, but in fact it was very good to be able to get the introduction introductory talk to show just how important it is to be able to measure the neonatal heart rate during the first minute after birth. Because I mean, it's generally accepted that if you've got a good heart rate, then that means the baby is perfectly healthy. The APGAR score includes the heart rate, but the heart rate is really the only important part of an APGAR score. It's impossible to have a heart rate of 0 and a perfectly pink baby with good tone and breathing. So without a heart rate, all the rest of the APGAR scores become virtually meaningless, or they're dependent upon the circulation. And in all the resuscitation recommendations, then heart rate is considered the major element of assessing the health of the baby. And auscultation is the recommended method, using just a standard stethoscope. But it's been recognized, of course, for years that that's not very accurate. It requires a bit of mental arithmetic and accurate counting, any noise. You can only count for a relatively short period if you're going to be able to work out fairly quickly what the heart rate is within that first minute. One of the ways to do it is to count for 10 seconds and then multiply by 6, or count for 6 seconds and multiply by 10. But you only need to miss one heartbeat and you get quite a significant variation in the answer. And then you're actually doing two things at the same time. You're listening and counting, you're looking at the clock. So again, there's bound to be variation. And to try and make this a bit more accurate, there's been a few approaches that this paper from Henry 2020, using a simple visual timer, they were able to show that in fact you could get a bit more accuracy from just auscultation. But the fact is it's not particularly accurate, and there's been numerous attempts recently to get a much more accurate method for determining the heart rate at birth. And of course, the ECG is one of the commonest ones. And in fact, this was a knowledge gap identified by ILCOR as how to best assess the ventilation. They assess the heart rate during resuscitation, and they need improved technology because applying an ECG takes time, and almost the full minute can be up before you can get the ECG actually on and working. Again, it takes a little bit of time for the apparatus to start functioning. Recently, there's the NeoBeat from Leerdal that uses dry electrodes. Quite a neat idea, really. Can be put on the baby pretty quickly. It's just like a pair of earphones, really, that goes around the baby's chest. I'll show you that shortly. and it's a dry electrode, so it doesn't actually need any specific contact with the skin, the baby's skin. It just needs to be very, very close to the baby's skin. But if all it does, of course, is produce a number, well, can you really believe that number? It doesn't give you an ECG tracing, and even if it did give you an ECG tracing, during resuscitation, you really be able to look at that ECG tracing and realize that it wasn't a pure PQRS T pattern. The other one is the sure pulse, and that relies on well, a sort of oximetry, a reflection photo plethysmography. So in other words, you look at the reflection rather than the transmission of the various light waves through the tissue. And again, a rather neat way that they adopted by incorporating it within what is a standard, of course, is to get the baby's cap on to keep the baby's head warm, where it's losing most of its heat, it's been shown to work quite well, but not necessarily in very asphyxiated babies. And if there isn't good circulation in the baby's hands or peripheral parts of the baby, will it be that much better in the baby's forehead? It might be a bit better, but of course in a really collapsed baby it almost certainly won't be, and you won't get the heart rate until you've already got some improved circulation. And then of course with an ECG, there's also the possibility, especially in a very sick baby, that you will get an ECG tracing, but in fact there's no contractions, what's called pulseless electrical activity of the heart. And that would certainly detract a bit from so these are the two methods, the sure pulse on the baby's forehead, and the ECG across the baby's chest. And both of these, as I say, have been shown to work well, but largely in healthy babies, or babies at least who have good peripheral circulation. Now, of course, perhaps for vaginal birth, there's no particular need for sterility, but for a cesarean section, of course, you need to have a sterile equipment, and the stethoscope cannot really be sterilized, and I can't imagine how the ECG and oximetry can be used in a sterile way. So for a cesarean section, you have a definite problem involving sterility. Of course, you can move the baby into an area that you have specified is not sterile, but with an arbitrary division between the non-sterile area where the neonatologists are working and the sterile area where the obstetrician is continuing to work. But that still leads to some sort of possible contamination. The latest European resuscitation guidelines, of course, assess breathing and heart rate. Then it also say about delayed cord clamping optimizes condition. So it's really during this time of delayed cord clamping that you need to get the heart rate to know what the heart rate is. The American guidelines now say that because of the inaccuracy of auscultation, they don't recommend a simple stethoscope for determining the heart rate. So that immediately means that there's no obvious way of providing this. They recommend that a 3-lead ECG is a reasonable, rapid, and accurate method of measuring the heart rate. But of course, the ECG is not going to give you an oxygenation rate. So oximetry is still important, but oximetry is only going to work once the baby's circulation and oxygenation is satisfactory. So it's not a method of identifying the heart rate, apart from the possibility of the neobead working on the baby's forehead. But for general oximetry in the periphery, it's not going to function well. Now, they also state that of course, it's the advantage of oximetry and the ECG is that they're continuous and that they're hands-free. So in other words, we don't need anybody to be holding anything on the baby. Whereas, of course, with a stethoscope, then you've got to hold something on the baby. This is the recent European guidelines, and again, they say continuous ECG, but of course, that's not readily available in low resource settings. So it's not going to be helpful in that situation. They also mention about Doppler ultrasound. Now, for the last 40 years or more, obstetricians and midwives have been carefully monitoring the fetal heart rate with Doppler ultrasound. Very often it's used antenatally, but during labor, we continuously measure and document the heart rate. And then the moment the baby is born, we abandon it as though, oh, it's not going to work on the baby, on a neonate. I don't know why on earth we thought that, but it's, you can literally say at a crash cesarean section, have somebody put the Doppler onto the mother's abdomen just to check that the heart rate is still there. The surgeon goes in, cuts open, gets the baby out, and then the moment the baby's born, we resort to something else, like auscultation. Auscultation having been proven to be of little use, or rather ineffective, when the baby was still inside. Now we forget that auscultation isn't much good, and we require an ECG or an oximetry, which, as I've already mentioned, has got significant limitations. Why not use the Doppler ultrasound? It's still there. Of course, if it's a cesarean section, then there may be problems with sterility, but I'll come to that shortly. It's just really the limitations of the ECG. This is the VentFirst trial is being carried out in the USA, and as it suggests, you vent first before clamping the cord. Of course, they have shown, there's difficulty with getting the equipment prepared, team training, etc. But one of the other things they identified was the difficulty in checking the heart rate during delayed cord clamping. Doppler ultrasound has been investigated in the last 5 or 8 years, maybe now. It, in fact, has been shown to be very effective in identifying the heart rate in a newborn baby. There's been 6 studies carried out, and I've done a systematic review, which I've published in Children on that. And it shows that the Doppler ultrasound works extremely well. The Doppler ultrasound sounds that you get from placing the Doppler on a baby's chest is exactly the same as the sounds you get from the mother's abdomen of the fetal sound in utero. So obstetricians and midwives are all very familiar with the sound, the Doppler sounds, and you can, to a certain extent, assess the rate. But of course, most of these machines will both display the heart rate and document it and record it onto a card or a memory card inside the machine. And it's known to be reliable even at the lowest heart rates. During labor, we can sometimes see the heart rate dipping down to 60, 50, and then coming back up again. So the technology is extremely reliable. So there's no real possibility of false results in the critically ill children. And it's readily available at certainly at all high-risk births and many low-risk births. One limitation, perhaps, is that it still requires somebody to hold the Doppler machine on the baby's chest. And certainly for resuscitation, that maybe is a limitation because it means that one member of your team is completely taken up just by holding the Doppler machine. But in fact, with a minor adaptation, it's perfectly possible to make this hands-free. And so now you have continuous heart rate monitoring, even on a baby that's requiring resuscitation and being moved about a little bit without anybody having to take attention to it. And that's what I'm going to show you this morning and tell you about the development. The Doppler, of course, for getting the fetal heart is got to be very directional because we don't know exactly where the baby's heart actually is. And so you've got to direct it with the little probe. And obviously it's got to be handheld. But in fact, it doesn't have to be directional when you're dealing with a neonate. You know exactly where the baby's heart is, and you know exactly the direction. And the direction is at 90 degrees to the baby's skin plane. So again, there's really no problem. So this is my systematic review of the 5 studies. that have been done. Well, in fact, the earliest one was 2017, so it's only 5 years back. So I just said that. I mean, another limitation of the probe, of course, is that not only does somebody have to hold it on the baby's chest, there's also a slight worry that you're pressing too hard, or for that matter, pressing not hard enough, keeping it in place. And then because it is very directional, you might sometimes be directing it in the wrong direction. The whole team, of course, can hear the heart rate. Neonatologists maybe at the moment aren't familiar to be able to hear the Doppler and be able to say, well, it's 110 or 130 or 60. And then, of course, the parents. They've been hearing the fetal heart rate throughout pregnancy, so they know what it sounds like to have a nice, healthy Doppler heart rate and how reassuring it is. So the parents can hear it too. And here's the modification. Pretty simple, but all I've done is taken the Doppler transducer from the top of and this with transducer gel will sit on the baby's chest, and the gel in fact is enough to hold it in place. And you only need to get approximately in front of the baby's heart before you can get perfectly good Doppler ultrasound. And of course, if it is a modification like this, you could have been using this to check the fetal heart a few minutes beforehand. I've made this modification, in fact, from a low-cost Chinese version, because I couldn't afford the £600 that it costs for normal standard. The standards that are standard machines that are used here in the UK. So I was able to get lots of these and fiddle about and eventually get the technology so that I can now record it and transmit the results wirelessly to a nearby computer. That's for documentation. Absolutely, the documentation, of course, absolutely essential for research, but very important also for general care. That we need to know what the heart rate is, whereas before there's no documentation with auscultation, because certainly no real-time documentation, and it's quite possible. For example, you maybe question whoever has been listening to the heart rate. Are you sure it was 60 or are you sure it was 120? Well, there's no way that they can go back and check. Whereas, of course, if we've got it documented, then we know. And there's the possibility of significant clinical research if we really know what these heart rates are during that first few minutes after birth. How am I doing now? 5 minutes. Yeah. So we have in fact done a small study so far on this system for neonates. And we've shown that the Doppler heart rate and the ECG heart rate are very compatible. So it definitely does work quite well. This was also shown in the systematic review amongst all these studies. And in fact, the Doppler tends to provide a faster heart rate than the ECG does. The ECG takes a little bit of time just to stabilize, whereas Doppler will very quickly come up with a digital heart rate. Not only that, of course, the moment you put the Doppler, the transducer onto the baby's chest, you get the sound, the heart sound, so you can hear it. Whereas with the ECG, then you're going to be getting some initially some sort of rubbish tracing. And that was shown consistently amongst the studies, and also in the study that I've been doing. So there's no latency with the ECG, and of course oximetry is well recognized, even in a perfectly healthy baby, not to work for the first minute, simply because the circulation in the peripheral tissues is quite poor. And of course, Doppler is very simple, especially if it's hands-free. Simple as auscultation, but without the disadvantage of having to count it and the single observer and the documentation. So it's got the advantages of the ECG and oximetry in that it's got documentation and is hands-free. And of course, it's low cost. So it's not going to be confined to high resource settings. I guess that the vast majority of low resource settings have Doppler ultrasound available. I mean, this machine I was able to get for £15, so that certainly shouldn't be a limitation in any low resource setting. Readily available if you're using it for the fetal heart rate, and of course it's an established technology, established that it's safe and it works. And of course, the majority of births for serious intrapartum hypoxia will be cesarean births. And these, of course, are the very babies that will require delayed cord clamping, or will benefit the most from delayed cord clamping and physiological transition. And also the babies that we most need to really know for sure the heart rate. But of course, all equipment requires to be sterile if you're going to apply it at cesarean section. And so, of course, Doppler ultrasound works through plastic. So the Doppler can be readily used in a sterile manner, whereas oximetry and ECG, I think, would be very difficult, if not impossible. And here I'm going to show you this is one of the standard devices used very commonly in the UK, the Sonicade. And what I've done is, again, extended the transducer and placed it inside a sterile polythene sheath. And so at cesarean section, this is just fed in, and the surgeon can now use this and apply it to the baby's chest. Obviously, we can have some sterile ultrasound gel placed on the transducer. I mean, it wouldn't maybe stay as well at cesarean section as a hands-free that I've just described, but this would be near enough hands-free, and certainly can just be held gently on the baby's chest. And now we've got the facility to provide an accurate and documented heart rate at caesarean section, with no fear of contamination with this long sterile tubing. Very cheap. Any manufacturer can change and provide this as an option for their Doppler devices, and now this can become a standard for measuring the heart rate in a neonatal and optimizing that birth with delayed cord clamping. Know what it is and see that it's increasing in rate, then these babies don't need resuscitation. And if it's increasing in rate, then that's probably because the baby doesn't actually want to start breathing. It's not physiologically optimal for this baby to start breathing until its blood volume and its heart rate have increased. We're only talking about maybe rarely a little bit longer than a minute. These are the results of my preliminary study. You can see that the heart rate and the ECG, the blue and the red, are very similar. And the numbers aren't really capable of being analysed statistically very carefully, but you can see there the Bland-Altman chart showing it's a fairly close correlation, apart from these couple of cases. And in fact, of course, it's possible. What I've been tried to do is show that just with a Doppler and oximetry, you can get 3 results of heart rate. So what I've done is I've put a little electrode up the middle of the transducer, connected it up through the equipment, put another electrode on the oximeter. And so now you've got 2 electrodes, one on the baby's chest, the other on the baby's foot or arm or hand, and you can get an ECG tracing. And I haven't done this on babies, but I have done it on an adult here. And you can see what I was describing earlier is that when this is the Doppler transducer being placed and then removed on the chest. And you can see that the moment it's placed on the chest, the Doppler starts working. That's in the blue. And then in the red, the ECG starts working. And then you can see how once they're both working, the correlation is pretty good. But the moment you take the Doppler off, the Doppler stops working. Sorry, the ECG stops working, but the Doppler has a bit of a latent period where it's working out, is there a heart rate or not, because it probably counts up over the previous 5 beats or something. But you can see it's really quite consistent, that. And so there's the possibility there of having, as I say, the 3 measures of heart rate on a baby, perhaps, that isn't responding well to resuscitation, and you move on. But you can be absolutely sure that these the heart rate that's being produced by the ECG and the oximetry correlates well with the Doppler. This was the parents' view of the Doppler, and it's 100%. They all thought it was that it caused no problem to the baby. I mean, all you're doing is putting something onto the baby's chest, If you have nice warm gel, then it hardly notices it. And everybody could hear the heart rate easily. And of course, they found it reassuring. This was not obviously particularly reassuring in their situation, but they would have found it reassuring if they thought the baby was at any risk. And they all thought that it was better than a stethoscope. And it had, in fact, even when these babies were moving about quite a bit, we found that the transducer stayed in position with the gel. So, and I say one of these babies was moving about quite a lot, but it still worked quite well. So that's the summary, but thank you very much.